Um, good afternoon to the chairpersons, respected chairpersons, and my dear students. At the outset, I bring greetings from my institution, Jawaharlal Nehru Medical College, and my university, Aligarh Muslim University. I will be speaking on difficult airway guideline, and my emphasis will be primarily on the All India Difficult Airway Association guideline. But however, I'll try to touch the different other guidelines which exist. Right. So the primary objective and aim of this my study would be, our talk would be that to provide a structured stepwise approach to manage unanticipated difficulty during the different stages of airway management, like face mask ventilation, insertion of supraglottic airway device, laryngoscopy, tracheal intubation. The next part is the strategy for extubation, which will be dealt by subsequent speaker. Now, to primarily reduce the likelihood adverse outcomes, but you don't guarantee that there will be always a good outcome. So what are the important factors on which the management depend? There are two most important factors which influence the performance during the airway management. One is the preparation, the other is implementation. By preparation, what we mean is the training of the person concerned, his experience, and then planning. And this can really can decrease the basic errors, especially during the emergency situations. And but however, failure to implement can cause disaster. So one needs to evaluate the situation and recall the rescue strategies which exist. And this is primarily because of the overload in the situation of stress. Now, what are the strategies which we have, which I also recommend? One most important thing is we need to assess. The primary important thing is we need to assess the difficulties which one can face, and then anticipate them as well, and practice and rehearse and implement the established guidelines. Modify as per your limitations, whatever facilities you have in your own institution, but however maintaining the essence of the guideline. Especially in crisis situation, always remember, do not implement any new guideline or anything which you have never done before, or you are aware of, and do not use any equipment which you have not used before. These are the two most important things which you always have to remember. And at any point of time, if you think that you're not being able to maintain the oxygenation of the patient, always you can skip the step and go to the rescue strategy which exist. Now, why is it that we need to change our practice? If you see the NAP4 report, the report says that the incidence of the problems, the difficulties are primarily related to airway events, and that is primarily, most importantly, it is very highly increased in intensive care unit, around 50 to 60 times more major events at that intensive care unit, and out of which 61% mortality was there as compared to the 14% in anesthesia. And out of the 38 deaths, 18 deaths were in the intensive care unit. Further, if you see, they had a very poor assessment of airway. Now, this is one of the most important factors. If you don't have an assessment, you don't have a backup plan as well. And naturally, you are unable to use your fiber optic because, you are unable to use your awake fiber optic equipment unless you are having a practice or you're practicing on that equipment. And naturally, in difficult situation, since you are going on for multiple attempts, if you don't have a proper guideline, so you are causing more trauma to the airway, and ultimately it becomes more difficulty in intubating or in maintaining airway in that situation. And finally, if you see, they have not used the supraglottic airway devices appropriately. So these are the problems which we encountered in the NAP4, and naturally we need to change. Now, in 2013, the ASA they came up with a practice guideline where they said that this categorized the different stages of difficulty. One is the difficulty with patient cooperation and consent, difficulty during mask ventilation, difficulty laryngoscopy, and difficulty intubation. Now, this was initially clubbed together. Now they separated as an independent or individual problem, and difficulty in surgical airway access. And for the first time, they came up with the concept that you can use the video laryngoscope if you are really having it and practiced over and having an experience over it, as a first choice. And 2015, the Difficult Airway Society, they came up with a lot of changes in their existing guideline. So what they said that they can go for direct or video laryngoscope maximum 3 times, but 3 attempts, but you can take a 4th attempt if you really have a good experienced anesthetist. Secondly, for the first time, they removed ILMA or LMA as the which was mentioned in the previous guideline. They came up with this second generation supraglottic airway device. Now, this was because meanwhile, a lot of series of supraglottic airway devices had come up, and second generations were there, which had a lot of advantages. So they incorporated that in the guideline, and they said that you can change the device for a maximum of 3 attempts, and you need to oxygenate and ventilate all through the process. And finally, and in fact, subsequently, what they said first time, they said that if you are not being able to ventilate this patient, you can go for a rescue ventilation and paralyze these patients. So this for the first time, they come up with the concept of paralyzing these patients, and you can use a 2% technique as well. And they came up with a new term, which was that CAICO, that is cannot intubate and cannot cannot oxygenate for the first time. And they said surgical airway was cricothyrotomy was best choice. Now, in 2016, IDA came up with a robust guideline, and they came up with 5 guidelines, which were all published in Indian Journal of Anesthesia. The unanticipated difficult airway in adult patients, in obstetric patients, in pediatric patients, and the management of difficult airway in extubation protocols in anticipated difficult airway. And for the first time in the world, in fact, they came up with the guideline, which is primarily tracheal intubation in intensive care unit. So I'll just touch all the guidelines. I will specifically emphasize on the difficult airway guideline in unanticipated difficult airway guideline in adult patients. But what are the changes there, or specific changes in the subsequent other guidelines, special situations? I will just touch them as well. So the first thing is the unanticipated difficult airway in adult patient, which has 4 stages, and the first stage is difficulty during tracheal intubation. Now, IDA always recommends that you need to assess the patient. Most importantly, they emphasize that you need to assess, but always remember, none of the tests are reliable. Always be prepared for difficulty. So you need to have a difficult airway trolley. Preparation, as I said, is very important. You need to have a preparation and a backup plan as well. But what IDA is recommending is that you have to go on pre-oxygenating this patient. They have already highly emphasized on pre-oxygenation during pre-oxygen and peri-intubation oxygenation as well. And there are various methods how you can pre-oxygenate these patients. Like you need to head up the position 20-degree, tidal volume breath for 3 minutes, 8 vital capacity breath for 60 seconds, 10 liters of flow of oxygen. You can target. You need to target an E2O2 or of more than 90%, and nitrous level of nitrogen level of less than 4%. You can use CPAP, PSV, and you can go for an apneic oxygenation. At the same time, you can go for Thrive as well. So these are the different methods of how we can pre-oxygenate or peri-intubation oxygen as well. Now, in the first step, if you are unable to intubate this patient for the first attempt, most importantly, you need to call for an help. And you continue the oxygenation for 15 liters per minute, but you're allowed to take maximum 2 attempts, and in between attempts you need to maintain the patients, and you need to go for a mask ventilation, but provided you take a second attempt only when you have the saturation of more than 95%. And during the second attempt, what you need to do is you optimize the position. You can go for external laryngeal manipulation, you can go for a stillate, bougie, and you can use change the technique. You can use change the operator as well. And always remember that during all these changes, you need to maintain the depth of anesthesia. Now, if you succeed in doing that tracheal intubation, then you confirm tracheal intubation by using capnography. Now, if you fail, resume your mask ventilation with 100% oxygen. Now, this is very important. Now, it is why is it that we are in fact, IDA has recommended the second attempt, 2 attempts in these patients. We need to know this because most of the cases, if you see, I'll come to that later on, that in the second attempt, when you fail in doing that, you need to maintain the patient's oxygenation and you continue nasal oxygenation of 15 liters per minute. And in the second step, you need to you go for oxygenation and insertion of supraglottic airway device. Now, preferably the second generation supraglottic airway device, because they have a lot of advantages, especially you can they have a very good sealing pressure. At the same time, you can aspirate the gastric content. So this is why second generation is always preferable, but we are recommending, the IDA recommends only 2 attempts if provided, if the patient can be maintained for an oxygen saturation of more than 95%. And always remember, you need to go for mask ventilation, and you can change the size or change the different devices also. We don't recommend a third attempt, because if you see in the third attempt, most of the studies, they said that you can maximum increase by 44.2% if you insert the device for the third attempt. And so that is better. Instead of going on for a third attempt, you can change for some other technique as well without wasting time. Now, if you succeed, then wake up the patient or continue anesthesia using supraglottic airway device. Or you need to, if you need a definitive airway, you need to intubate through the supraglottic airway device with the help of a fiber optic bronchoscope, or you can go for tracheostomy as well. Now, if you fail to go insert a supraglottic airway device, then you go to step 3. Now, in step 3, which is a rescue face mask ventilation, so continue the nasal oxygenation of 15 liters per minute, and you ensure that the patient has a good neuromuscular blockade. And you go for a final attempt of oxygenation with a face mask, and you take all the adjuncts which are then optimal technique which can be used during this process. Now, if you succeed, wake up the patient. Now, if you fail, you declare this state as a complete ventilation failure. Now, complete ventilation failure, what do you mean by complete ventilation failure? Now, this is a situation where the intubation, when you're not being able to intubate, that means intubation, ventilation with supraglottic airway device and face mask ventilation have all failed after giving the best attempt, even if oxygenation may be maintained. Now, this is a term which has been coined by IDA, and we recommend that this is the trigger for the emergency cricothyroidotomy, that is the step 4. So during this process, you need to oxygenate the patient with 15 liters of oxygen, and your effort of maintaining the effort of mask ventilation should continue, and perform these rescue strategies, rescue methods, or emergency cricothyroidotomy. But very importantly, before going with this, you always call for an additional help. So while going for the rescue strategies, you always need to position the patient with a slightly head extended position so that the larynx come anteriorly, and you try to identify the cricothyroid membrane by using your laryngeal shake hand method, and naturally you go with the surgical cricothyroidotomy. Now, the surgical cricothyrodomy has 4 stages, 4 steps, and 4 devices. 4 step is tab, twist, bougie, tube, which gives 100% success rate. And the 4 devices which are needed is a scalpel, a bougie, a tube, and a syringe. Now, first step is tab. When you give a stab, which is I try to identify first. You identify the cricothyroid membrane, stabilize it with your non-dependent hand, and you give a horizontal stab incision, and after stab incision you twist it so that the belly is towards the caudal side, and you bring the scalpel towards you so as to create a space, and in between the space, within the space, you pass a bougie. So when you pass a bougie, you always confirm it that you can easily freely move that bougie, and then after this you try to change your hand. When you change your hand, naturally you try to put the tube, railroad the tube through the bougie. Now, these are the 4 steps which is needed when you're trying to for a surgical airway. Now, the other steps, which are other strategies which are there, or rescue strategies, are you can use a narrow bore, which is a narrow bore tube, which is less than 4 millimeter, which is cannula over a needle, which is primarily quick track or Melcar. We have a wide bore, which is more than 4 millimeter cannula over a trocar, which is ultraplug, which gives a 57% success rate. We can use the wire guided cylinder technique, or you can use a pressure regulated transtracheal jet ventilation with the needle cricothyrotomy. Now, after this, you need to go for a post-procedural plan, because whatever problems you have faced, you must need, first important thing is you need to first assess the problem, and then further airway management, because all this is primarily you're buying time when you go for a rescue strategy, and you need to have a definitive airway. So further airway management plan should be always chalked out or planned, and you since you have there's some sort of trauma could be there, so you need to treat that edema if suspected, monitor whatever complications has taken place, and need to most importantly counsel the patient and document whatever problems you have experienced during this process. So in 2020, IDA came up with the guideline, which was primarily meant for patients who are suffering from COVID. Now, in that, there were certain changes which are primarily they came up with the planning, preparation, procedure, and post-procedural care, and what are the things which we either do not recommend. Now, in teaching and training, either recommends that you should always have the all those procedures which generates aerosol should be avoided or limited or minimized as much as possible. You should always have a good training on hand hygiene, doning and doping. Specific measures during the airway management, like prevent transmission of infection, should always be done. And you need to mock drill, because you need to train yourself wearing a PPE kit and then going for an airway management. So these things, training should be always there. Operating room environment was most importantly, you should have a negative pressure chamber. But if you don't have it, you can have a closed room with an exhaust system, so as to prevent as much as possible the aerosol generation. And additional resources, always you need the PPE kit, the transparent plastic sheets, or a customized intubation box, which has a lot of controversy. Standby airway cart should always be there. And one important thing is HME filter should always be there, at least 2, so as to prevent yourself from being exposed to that aerosol. Video laryngoscope is always preferred, and closed suction system should always be there. Surgical cricothyrotomy equipment should be there, and disinfectant system should always be available. Now, team preparation, team dynamics is very important, and patient preparation always need to be there. You need to go for a surgical mask over the patient, cover the patient with a transparent sheet, and transfer the patient directly to the operating room, bypassing any holding area. So these are the precautions which you need to take as to prevent the transmission of the infection. And in the operation room, obviously you need to use a HME filter which should be attached between the patient's the mask and the breathing circuit, and at the same time towards the ventilator as well. The side stream capnography is better, it should be used, and video laryngoscope with closed suction system should be used, and standby airway cart should always be there. Now, IDA recommends that at least 2 people should be there intubating these patients, 1 or 2 experienced person, and the third person should be outside that room who will be monitoring these patients continuously. So whenever help is needed, he will be there helping these patients. So this is how the IDA has given a chart or an algorithm format. And what IDA do not recommend, very importantly, this is very importantly, you need to know this, is mask ventilation as less as possible. You can go for if you are really needing a mask ventilation, you should see that there's a very close fitting mask. Then you can go for a gentle mask ventilation with a close fit mask. And either again, you should limit your high flow nasal oxygenation as much as possible, and NIV should also be limited as much as possible. Disconnection of the circuit, as I said, should always be as less as possible. And when you disconnect it, it is better that you clamp the endotracheal tube, or you can put an HME filter over the endotracheal tube, so as to prevent the liberation of or spreading of that the infections. And airway manipulation and airway exchange with an airway exchange catheters should always be limited as possible. Tracheostomy and tracheal intubation through supraortic airway device is it is not recommended, and cannula over needle cricothyrotomy is not recommended. You can go for a surgical cricothyrotomy if need be, and nebulization and gargles are also not recommended. So let's come to the next. In obstetric patients, incidence of difficult airway in obstetric is 1 in 2 to 4, that is around 8%, 8 times more. You always expect that these patients are full stomach. So naturally, at the same time, they have the esophageal sphincter tone is decreased. So you always anticipate that these patients can go for there's always a chance of aspiration. So and at the same time, because of the lung changes in the lung characteristic during pregnancy, they have a rapid desaturation. So and at the same time, before you take up these patients, always try to access the front of neck, the cricothyroid membrane in these patients, and priority is always given to the mother's safety. So this also has 4 steps, and the 5th step is primarily for the cardiac arrest situations. Now, primarily we have call for an help in the first step. And we need here in pregnant lady, we don't recommend two attempts. We recommend only one attempt. If you fail the first attempt, only one attempt is been given, allowed, and an SpO2 of more than, provided the patient has an SpO2 of more than 95%, you can go for a masked ventilation by closing the APL valve so as to create a pressure of less than 20 centimeter of water. And you need to at the same time optimize the position in the second attempt, and you need to, if needed, you can release the cricoid pressure partially or completely. And always remember that you need to elevate the patient's head so as to optimize the position. Go for a rapid sequence intubation, and if you succeed in tracheal intubation, you confirm with capnography. If you fail, then obviously you go to the second step where you insert a supraglottic airway device, where you can give for maximum 2 attempts. You are always remember that if the fetus is not reassuring, delivery of baby is mandatory. So subsequently intubate this patient with fiber optic and guided, and then deliver the baby. But if the fetus and mother is stable, and so you don't need to have an immediate delivery, it is better that you awake the patient and go for a subsequent neuraxial block. In the third step, most importantly is fourth step, in fact, if you fail, if you see that you are not being able to go for a face mask ventilation at the third step, in the fourth step, you need to go for a surgical cryo. But meanwhile, if the patient sustains cardiac arrest, so then you need to perform a CPR with left uterine displacement, and the CPR should be, and the baby should be delivered within 4 minutes of cardiac arrest. So in patients with pediatric population, most of the guidelines are primarily being derived from the adults. Margin of safety is narrow in these patients, so mismanagement can cause disaster. And the incidence is around 0.24% to 4.7% in infants, and whereas it's slightly higher in adult patients. Slightly, it's better in adult patients, which is around 0.07 to 0.7%, and older patients, older children. And you have again a 4-step criteria here. So again, here you are given, once you fail in first attempt, one more attempt has been given. So you are giving maximum 2 attempts, provided you're being able to maintain oxygen saturation of 95%. But here there's a rider. If you think that you have an experienced anesthetist who is primarily experienced in pediatric anesthesia, then you can give a third attempt there, provided you have an experience who has an experience in pediatric anesthesia. So third attempt is only advised when you have a person who's frequently managing these patients in pediatric patients. So this is very important. You need to know the change. And the other thing is that if these patients primarily they don't have a complete ventilation failure scenario, this is very rare. And the technical difficulty of locating the correct anatomical structures are always there, because because of the pediatric age group, you are not being able to locate the cricothyroid membrane. So in those situations, you don't delay the emergency rescue. Should always be as early as possible before the patient goes to desaturation. Now, if the child is less than 8 years and you have a surgical help available, then you go for tracheostomy. If the child is if you see that you don't have a surgical help, and the patient's if the child is less than 5 years, you go for transtracheal needle puncture. But if he is around 5 to 7 years, you go for needle cricothyrotomy. So this is the changes which we have. At the same time, if the child is more than 8 years, then you always go for needle cricothyrotomy with a pressure regulated jet ventilation, and attempt to keep the upper airway patent as much as possible. So these are the changes and differences in pediatric patients. Now, as I said, for the first time, the IDA came up with a robust guideline for the intubation, tracheal intubation in ICU patients, and they have 5 steps here. The incidence of difficult airway ranging between 8 to 13%, and the incidence of complications during intubation in critically ill patients in ICU, as I said, is 22 to 54%. And what NAP has reported is 60% of complications in ICU leads to death, as compared to only 14%. And we recommend the assessment of difficult airway in intensive care unit is the Macocha scoring system. We'll come to that later. Now, what are the challenges you face while you are maintaining a patient, you are intubating in intensive care unit? This could be the ICU-related factors, which is primarily infrastructure, equipment, and timing. So infrastructure, lack of space around the patient. Equipment, you are not having those equipment which is needed during intubation. And timing. In intubation, in intensive care unit, you need to intubate at any point of time, whether it's night or daytime, whatever it is. So you have always a risk factor with the availability of your intensivist. The second thing is the patient factors. You are not being able to assess the patient's airway because the patients are most of the time uncooperative or comatose. So you cannot be, the patient is not cooperative, so you cannot exactly assess the difficult airway. And risk of aspiration is always there. And the anatomy is challenging because a lot of distortion has taken place, and inefficient pre-oxygenation is always there. And these patients, because of their cardiac and respiratory reserve, they desaturate very fast. And they are hemodynamically, most of the time, very hemodynamically unstable. And waking up is, most importantly, is not an option in these patients. So you have to go for a definitive airway. So these are the challenges which are related to patient. And there again, for operator factor, which are training, as I said, most of the intensive care unit might not have an experienced airway manager. So training is there. Experience of the person is again a problem, and stress. They're always under stress while managing these patients. So these are the problems which a patient can face, or an intensivist or an airway manager can face. Now, this is what is a Macocha scoring, which has seven parameters and which has 12 scoring. And if the scoring is more than 2, then always anticipate that this patient can have a difficult airway, and try to, most importantly, in intensive care unit, try to document it, because probably when you are assessing, the patient is conscious and cooperative. So you are not needing the patient to go for an airway, to go for an intubation. But subsequently, when the patient deteriorates, probably he'll not be cooperative. So at that point of time, you'll not be able to assess the difficulty. So it is always better you preempt, you always go for prediction and go for a Macocha scoring, document it in the case sheet. So subsequently, when a second person comes in and he needs to intubate this patient, he knows that this patient is predicted difficulty. So naturally, he can go for an additional help. So this is very important. You always try to document it in your case sheet. So the for first is pre-oxygenation step 1, where IDA recommends 2 experienced person, and out of which 1 person is 2 person, out of which 1 person should be experienced as an airway manager. And you always need to optimize these patients on oxygenation, where you can use a non-invasive ventilation, non-invasive ventilator with 100% oxygen and a PEEP of 5 centimeter water, or pressure support of 5 to 15 centimeter for 3 minutes, or you can go for a high flow nasal cannulation therapy, so as to optimize these patients with oxygen. Now, because these patients their respiratory reserve is very less, so you have to keep this in mind, that you need to optimize this patient. And always remember that these patients are hemodynamically unstable, so you have to choose the inducing agents which are cardiac stable, like for instance cetomidate, or you can go for ketamine as well. You can supplement to some amount of fluid in this patient, so that the patient's hemodynamic, they don't straight away go to shock after you give, they don't collapse after you give induce this patient. You can intubate with succinylcholine, or if you have a rocklinium, you can intubate if succinylcholine is contraindicated. So use required pressure, which if you think you can release it as well. You need to go for a back mask ventilation, and you can use an external PEEP. You can use PEEP through ventilator as well. So now if you think that face mask ventilation is unsuccessful, then you immediately call for an help and go for a single attempt at tracheal intubation, provided if you are being able to maintain a saturation of 95%. If you think that face mask ventilation is possible, then continue nasal oxygenation and go for laryngoscopy and intubation with 15 liters of water or high flow nasal cannulation. Maximum 2 attempts are given, and repeat only if the patient saturation is more than 95%. In the second attempt, obviously you optimize whatever is there in the adult guideline, you optimize, and always maintain the depth of anesthesia. Now, if you succeed, you confirm tracheal intubation with capnography. If you fail, you go to the second step, where you when you insert a supraglottic airway device preferably the second generation supraglottic airway device, you are given allowed maximum 2 attempts, and in between attempts you can change the size, the device as well, and maintain the depth of anesthesia. Now here, if you succeed, you straight away, because since you know that you need a definitive airway, you straight away go with a percutaneous tracheostomy or surgical tracheostomy. If you think that you have a fiber optic bronchoscope and expert, so you can use intubate this patient through that. But if you fail inserting a supraglottic airway device, you can go for a rescue face mask ventilation by continuing your oxygen high flow or a flow of 15 liters per minute, but ensure that the patient has a full neuromuscular blockade. But if you succeed, if you succeed this, then I still go for surgical or percutaneous tracheostomy. If you fail, you declare this step as complete ventilation failure and go for an additional help. And this process is the same as in case of adult unanticipated difficult airway. Subsequently, go for post-procedural plan. Now, in 2019, the Difficult Airway Society, they came up with an awake tracheal intubation guideline protocol, and they said that they came up with a mnemonic, which is STOP, where S is a small s, where the S is for sedation, T is for topicalization, O is for oxygenation, and P is for performance. Now, oxygenation, they have always emphasized on high flow nasal oxygen cannula, and then you need to titrate to 30 to 70 liters per minute, and continue this throughout the procedure. You need to topicalize these patients where they've increased the dose to 9 milligram per kilo body weight, where you can go for sprays, you can go for gargle, you can go for infiltration. So all this, and you can go for nasal pledgets. So they are all there. Sedation, they have recommended a mild sedation with remifentanil, and they have emphasized, most importantly, the performance of the patient, where they said that they are also at the same time saying that you need to allow the airway manager practice awake tracheal intubation and let them get experienced and expertise on awake tracheal intubation, where you can go for either awake tracheal fiber optic intubation or awake tracheal video laryngoscope assisted intubation. So this is what they have come up with in 2019. Now, Nicholas Crime, he came up with a vortex approach. Now, where he said it's a single tool that is flexible enough to be applied in all situations, and it is independent of context, the patient type, or the primary intended airway device. Now, what he means is that you can either use any of this device at any point of time. So you can begin with at any point of time with any of this device, and it works with two assumptions. But provided, he said, the rider is that whoever is using this vortex approach to be competent to manage advanced airway independently, promptly, previously acquired this knowledge and skills. That means he has already having this knowledge of managing a difficult airway situation, and he is trained in its use before the occurrence of any airway crisis. At the same time, the characteristics of this device this approach is there are three non-surgical techniques. The non-surgical technique is a fast face mask ventilation, the supraglottic airway device, and the endotracheal tube. Now, you can start with any of this before managing an airway. Whatever you start with, you can change over in any direction. Either if you start with face mask, you can go to tracheal intubation or with endotracheal tube, or if you start with supraglottic, you can go to tracheal intubation, or you can go for face mask ventilation. So if you're after giving best effort, by saying best effort, he's saying that you can give maximum 3 attempts in each of these lifelines. He considers this as lifelines. And if you think that you need to change, you can change in any direction, and airway management can commence with any lifeline and proceed between the remaining ones in any sequence. And always, he has said that once you fail in this, you can go for a surgical technique, where he is also saying that he has named it as Kaiko, and he has said as and the front of neck axis. So the key points are: assess your airway. Most importantly, what IDA recommends is you need to assess always, because unless you assess, you don't have you cannot predict, and you cannot have a backup plan. So always have an assessment, pre-oxygenate, and pre-oxygenate. This is what one is very important. It could be pre-oxygenation, peri-intubation oxygenation as well. And we have all the different strategies of pre-oxygenation, which you have to keep in mind. Your target should be always around more than 95%. And if you're not being able to maintain that, you escalate your interventions by using your the pre-oxygenation strategies. Limit the number of intubation, both in intubation and along with supraglottic airway device attempts as per the guidelines, which AIDA states. Never hesitate to call for an additional help. This is very important. When you go to step 4, you always go for an additional help, where the third person who comes in, he has a different concept. He has a clear-headed mind. He's not tubular in his thought process. So he gives an additional input while he comes in a rescue status, because you are already exhausted and overstressed with all sorts of adrenal surge. So naturally, you always go for an additional help. Complete ventilation failure should be a trigger for emergency crico. You have the 4 steps, 4 devices. Have a post-procedural plan and standard reporting UA, DA, and along with that, you extubate electively. Now, always remember, extubation is a control system. It's an elective process. You don't hurry in extubation. Extubate in a controlled environment. Never use a guideline and an equipment for the first time in crisis. Follow a guideline which best fits as per your limitations. Preparedness and rehearsal are the key to overcome crisis situation. Thank you so much.